to the virtual webinar on critical conversations in advanced renal cell carcinoma. Now, it is my pleasure to invite our program director, Dr. Ashok Kumar Ved, sir. He is a chairman in the Department of Medical Oncology and Hematology at Medanta, the MedCity. Over to you, sir.
Good evening, everyone. Friends, welcome once again to one of our online meetings, which are more focused. They are more topic-centric, disease-centric, and we try and bring about the recent presentations from the major conferences, followed by one of the topics which we choose to discuss on a broader platform. I'm happy to share with you that we already have about 250 registrations for this event and from across geographies. And with the programs getting more popular, we are actually getting many registrations from countries across the globe. Today's meeting is focused on advanced RCC, and we are joined by Dr. Rajat Saha, who would be speaking on the kidney cancer highlights from ASCO 2024. And Amish is going to take us through a very important topic. As the usage of IOs and the targeted agents has grown, so have the patients who have failed frontline treatment. And believe me, it's a hard choice. It's a very, very difficult proposition in the clinic to choose treatment in the second and the subsequent line treatments. Amish is going to take us through that, and there is an expert discussion on the clinical adaptation of new publications. And can we change the practice tomorrow morning? Dr. Shaina is going to lead the panel discussion. I have the pleasure of introducing our chairperson of the meeting, Dr. Narayan Kuti Warrior, and a good friend. Welcome, NK, to the program, and we hope to see you more often on this. He is the Medical Director and Senior Consultant, Department of Medical Oncology, MVR Cancer Center and Research Institute, Calicut. Thank you so much, and over to you, NK.
Thank you, Dr. Vaid, for this invitation, and it's an honor and pleasure. Today, I must congratulate you for arranging such a wonderful educational symposium. We all know that there are a lot of things have changed in the past 1 year in this in this scenario of metastatic renal cell carcinoma. Several updates have come. So it's the importance of this today's meeting. And as you rightly pointed out, there are good discussions to follow, and we are going to have a panel also. So I'm sure the change in scenario of the renal cell carcinoma, especially the changing paradigm, will be discussed in detail. The last 1 year, we have seen updates from ASCO and other meetings about the adjuvant pembrolizumab getting approved for, especially after the resection of the tumor. And then 2 important trials, updates on the nivolumab and ipilimumab, which has completed more than 8 years in the management of renal cell carcinoma, which is something very exciting for all of us, as well as the several molecules like combinations like cabozantinib and nivolumab, and then even the second line belzutifan also got approved recently. So we are going to have it's a real update, and without wasting further time, I will invite Rajat to start his first talk on the updates from the ASCO 24. Over to Rajat.
Thank you very much, Dr. Warrior, and I thank Dr. Ashok Vaid and for inviting me to present the recent advances as recent as ASCO 2024, which was recently concluded 2 months back. And some abstracts were presented in the field of kidney cancer. And we will just go through few of the abstracts, and let's see what the new advancements are happening, and the new thought processes are going in that direction. So if the organizers would be kind enough to share the slides. or should I share it from my side?
Yes, sir. You want to share?
Let me see.
Yes, yes, yes. Sure, no issue, sir.
So, okay. So I think so. Just confirm whether the slides are moving or not. Okay.
Yes, just change the slides. It is moving, sir.
It is moving. So fair
Yes.
enough. So I will be discussing about 6 abstracts. This 15 to 20 minutes, which have been given to me. And the first abstract is abstract 4504. It is an extension of the CLEAR study. The CLEAR study, as we all know, is the study of combination of pembrolizumab plus lenvatinib in advanced renal cell carcinoma first line setting. So in this abstract 4504, the researchers were looking for biomarkers in the tumor samples taken from patients of advanced kidney cancer that received treatment with pembro plus lenvatinib combination or sunitinib in the first line setting. So they looked at various biomarkers, including the PDL1, and then the genes of the tumors, etc., were also looked at. And in addition, 5 genes were studied in specific. One is the VHL von Hippel-Lindau gene, one is the PBRM1 gene, ESTT2 gene, BAP1, and KDM5C. So as of now, we are only aware of the VHL gene, which was very prominent in the kidney pathogenesis, but other genes were also identified and studied separately. For all the biomarkers, patients treated with lenvatinib plus pembro showed a longer time to when the treatment stopped working and the cancer started going ahead. So overall, means irrespective of any expression of these biomarkers, basically pembro plus lenvatinib showed an improved progression-free survival. Overall, none of these biomarkers were able to predict a better response with the combination therapy, and regardless of which biomarker was looked at, all patients showed longer progression-free survival if treated with a combination of lenvatinib plus pembrolizumab. So that was the overall outcome of this biomarker analysis. So as of now, nothing to predict which patient will respond better or not. And at least in this study group, almost all the patients responded. Now, let us look at the keynote 426, which was the pioneer study for pembro plus axitinib, the IO plus VEGF combination, the pembro plus axitinib versus sunitinib. And here also, this is also a biomarker analysis study. The researchers looked for biomarkers of response to treatment with pembro plus axitinib or sunitinib in the tumor samples. So they retrospectively checked all the tumor samples, and they looked for biomarkers called the T cell inflamed gene signature. So this is a T cell inflamed gene signature, which they means an aggregate of biomarkers was there, and an angiogenesis gene signature done by RNA sequencing, and PDL1. We do always do the PDL1. However, in kidney tumors, we generally do not check for PDL1 as a prerequisite prior to starting these IO drugs. But still, they did the PDL1, they did the angiogenesis gene signature, and they did the unique biomarker aggregation called as T cell inflamed gene signature. So here they found the investigators found a strong relationship between T cell inflamed gene expression profile, a marker that is associated with generally an inflamed tumor state, and patient outcomes in patients that received treatment with pembro plus axitinib. Those with high levels of T cell inflamed GEP had better response rates, progression-free survival, and overall survival than those who had low levels. Conversely, in patients who received a sunitinib, the angiogenesis gene signatures was associated with a better response rates, progression-free survival, and overall survival. Importantly, regardless of the gene expression profile, patients who received axitinib plus pembro showed better outcomes than those who received sunitinib. So in the end, these biomarkers don't help us choose between these regimens. However, it definitely gives a food for thought that the T cell inflamed gene signature, if we are able to predict in our tumors, then these patients should perform better with the IO drugs upfront. This is the third abstract which I am trying to discuss here. It is the abstract 4506 on IM motion 101 study. Now here they analyzed, this is also a biomarker analysis. They analyzed the circulating kidney injury molecule KIM1 in this trial. It is a randomized phase 3 study of adjuvant atezolizumab versus placebo in patients who have completely resected RCCs at increased risk of recurrence after resection. So it's an adjuvant atezo trial. And here they stratified the patient into KIM high or KIM low. So kidney injury molecule high or kidney injury molecule low biomarker. The median DFS of the KIM high population was 35.9 months, whereas in the KIM low it was 57.2 months. And the median DFS in the KIM high population was not achieved, not evaluated in the atezo arm versus 21.2 in the placebo arm, whereas in the KIM low patients, it was 57.2 months in the atezo arm with not evaluable in the placebo arm. So overall, the message we can derive from this is in the KIM low population, atezo arm will definitely perform quite better. So in the results, the investigators noticed that the patient had high blood levels of the protein after nephrectomy were at high risk of recurring. And additionally, patients with a higher baseline KIM1 demonstrated benefit with adjuvant. So ultimately, a high KIM1 means a higher chances of recurrence. Higher chances of recurrence means that these are the patients who are likely to probably respond to some adjuvant treatment given. So that adjuvant treatment here is adjuvant atezolizumab, and these patients showed a longer progression-free survival compared to placebo. So the researchers concluded that KIM1, kidney injury molecule 1, may be a biomarker for recurrence of kidney cancer and could help in selecting patients that will benefit from further therapy after surgery. So either if in a KIM low patient, we may offer the patient observation, but in a KIM high patient, we should probably advise them adjuvant treatment. And more research obviously is needed to confirm the role of KIM1 as a biomarker of poor prognosis in localized kidney cancers. So that was an interesting trial to stratify the adjuvant treatment of renal cell cancer. Next abstract which I'm going to discuss is the abstract 4508, which is the Javelin Renal 101 trial based on avelumab. Now this is the Javelin Renal 101 trial is avelumab plus axitinib versus sunitinib in patients with advanced RCCs, and the final overall survival analysis from the Javelin trial. And in this, basically, in the PDL, the investigators again stratified into PDL1 population and overall population. Now, in the PDL1 positive population, the median overall survival was 43.2 months in the avelumab plus axitinib versus 36.2 months in the sunitinib arm. And the overall population, it was 44.8 months versus 38.9 months. So the hazard rate for overall survival in the PDL1 population stood at 0.86. That means a 14% improvement in overall survival with the addition of avelumab in PDL1 population, whereas the hazard rates dipped slightly low at 0.88 for the overall population. Looking at the progression-free survival, definitely the progression-free survival with the combination of avelumab plus axitinib was quite statistically significant, and it stood at 0.57, which is highly statistically significant. So, and in the overall population also, it was highly statistically significant. The overall response rates was definitely better for the combination at 64.8% versus 31.4% in the PDL1 population and 59.7% versus 32% in the overall population. So overall, what we can see from the overall survival analysis is that there is a statistically significant improvement in the progression-free survival when we do avelumab plus axitinib in the PDL1 population and also in the unselected overall population. That is statistically significant. But when it comes to the overall survival analysis, whether it is in the PDL1 population or it is in the overall population, the statistical significance was not met, and there was a minor improvement in the hazard ratio or in the probably giving the message that overall survival is not yet reached that statistical significance for the combination. So in this 900 patient study, the patients were followed for an average of just over 7 years. So the overall impression was that the lack of overall survival benefit does question whether PD-L1 inhibitors like avelumab are not as effective as PD-1 inhibitors like pembrolizumab for kidney cancer. So that is a very fine point which they have raised, that PD-1 inhibitors like pembrolizumab has probably a better action versus PD-L1, which is the avelumab. So this is abstract 4512. It's a retrospective study of it's a multi-institutional analysis of outcomes with first-line systemic therapy for 99 patients with metastatic chromophobe renal cell carcinoma. So whatever the discussions we have done till now, all the trials are generally conducted in the clear cell carcinoma subgroup, which is the most common subgroup. Here, it's a retrospective study for 99 patients in chromophobe renal cell carcinoma. And this retrospective study looked at information on the frontline treatment of these 99 patients. The patients were categorized into 4 treatment groups: immuno plus TKI combination, immuno alone combination, targeted therapy combination, or targeted therapy alone. So these were the 4 treatments which were offered to these chromophobe renal cell carcinoma. And here they showed that the targeted monotherapy had 54 patients, IO targeted doublet had 17 patients, targeted doublet like lenvatinib everolimus had 14 patients, and pure IO, Nivo EP or Nivo, had 14 patients. And the median time to tumor failure was highest in the targeted doublet or the IO targeted group. So, and the median OS again was highest in the targeted doublet or the or also the IO and targeted group. And again, in the pure IO group, it was not reached. Even though the numbers here are very low, but what the trend we can see from here, that a single targeted monotherapy like sunitinib is definitely not working well in the chromophobe renal cell carcinoma. That is for sure. What we can do is definitely we can offer them IO targeted doublet or a pure IO combination or a targeted doublet. So it is just still food for thought because of the lack of high number of patients in this chromophobe renal cell carcinoma patients. No randomized trials can be performed in this subset. The next abstract which I'm going to discuss is the TPS 4611. It's the Stellar 304. Now, this is basically zanzalintinib, which is plus nivolumab in non-clear cell renal cell carcinoma. So this is a phase 3 global study looking to enroll patients with papillary, unclassified, or translocation kidney cancer, including sarcomatoid kidney cancer. So a lot of patients of clear cell cancer have sarcomatoid variant. So in this, these patients probably may also be included in this. Patients with chromophobe, renal, medullary, or collecting duct subtypes or belly neat subtypes are excluded from the study. So only papillary, unclassified, or translocation kidney cancers are included. Patients should be untreated. So, but one adjuvant treatment is allowed. So basically, these are first-line stellar study, and the patients are randomized in 2:1 fashion to zanzalintinib plus nivo or sunitinib alone. The primary endpoints are the time when the treatment stops working and grows again. So the conclusion of this stellar trial was that the best first-line patients for advanced kidney cancer is a combination of immunotherapy and VEGF TKI, which is nivolumab plus cabozantinib, or a combination of immunotherapies like nivolumab plus ipilimumab. Now, with these combinations, the outcome of patients with the advanced kidney cancers have improved significantly. Furthermore, there is a percentage of patients who achieve a complete response. I am yet to achieve a complete response in any of my patients, but some patients do achieve, especially with pembro-lenva combination, meaning that in some patients there is a complete shrinkage of all mets. In the case of the nivo plus cabozantinib group patients, approximately 9% of the patients achieve a complete response. Further therapies are being looked at see it is always not sort of an abscopal effect, which is generally seen with when we give radiation therapy just before immunotherapy to increase the immunogenicity in the blood. Okay. The outcome from the stellar study is not yet out, but overall, what I have just read out as the overall thought process and the overall conclusion of all the studies combined. And as of now, we definitely do not have any major biomarker profile to kind of predict which patient will respond to IO, which patient will respond to IO plus TKI. So yet we are not yet able to zero down on the biomarker analysis. With that, I would like to end my presentation, and thank you very much, organizers, for giving me this opportunity. Thank you very much.
Yeah, thank you, Rajat, for your talk on the update of various meetings. Thank you again for keeping the time, and it was an excellent presentation, good clarity of points. I don't know whether we have received any questions to Rajat. Otherwise, be online. We will come back with the questions. So now I think I will call upon. Call upon Dr. So second line of management. Amish Vora is already ready with the presentation. Amish, can you take over now?
Thank you, sir.
Yeah.
So my screen is visible?
Yes, sir, it is visible.
Okay. Now I thank Dr. Ashok Vaid, sir, as always. He does wonderful programs, and not only programs, but on one-to-one also, he's always available for teaching. And I keep learning from sir from time to time, keep disturbing him all the time. So today's topic is metastatic RCC, second line and beyond. That is the topic which was given to me. We will talk of clear cell carcinoma, but I always, Rajat's one of the abstract was very interesting, 99 chromophobe RCC, and to see that doublet of TKI plus, mTOR inhibitor works one of the best. So that is one of the learning which we got. I will be also presenting the doublet TKI plus mTOR in my presentation. But thank you, Rajat, for sharing such wonderful abstracts. So metastatic RCC, as Ashok Vaid sir said, that we are so spoiled with the first line choices that I think the second line becomes a nightmare for all of us, because I think every drug combination wants to come to the first line, and rightly so, because you all always want the first line to be the best line. So I thought that let me present a case and then build up our presentation on the same. So this is the real case, a 66-year-old male diagnosed with localized RCC in July of 2022. He was operated upon and the nephrectomy single-sided was done. The patient was kept on follow-up, but within 4 months, January of 2023, CT scan of thorax had shown 2 lung nodules. This is the time when patient came to me. Both the nodules were 6 mm and 4 mm nodules which were there. So I told him that let's observe, let's not rush. He is absolutely asymptomatic. We did a CT scan of the thorax after 3 months, and there was 1 more lung nodule. This is the time I took opinion of 2 other radiologists, and everybody said that it was not present in January 2023. So we said, okay, let's do an FNAC, and it turned out to be positive for malignancy. Morphology was similar to renal cell carcinoma. Patient was still completely asymptomatic. All other parameters were absolutely normal. So by IMDC risk, he was intermediate. At this point of time, I again discussed the option of observation, though I was not very keen because there was 1 lung nodule, and within 4 months of surgery, the lung nodules had appeared. But I did discuss the option of observation. Patient also was not keen. So we started this patient on nivolumab and ipilimumab combination. Why did we start IO plus IO? For 2 reasons. One reason is that patient was asymptomatic. The tumor load was less. Patient fitted into the checkmate criteria. of intermediate stroke high risk criteria. And Nivo EP, one of the best thing was you give 4 doses of Nivo plus EP 3 weekly. After that, you have a maintenance of nivolumab. Now, this, according to me, is very, very patient-friendly regimen, and that's the reason we started this. 4 months later, patient's PET CT, stable disease. 8 months later, partial response. I kept these 2 lines just to tell in case if the students are, attending. Nowadays, we are seeing a lot IO patients who are achieving response little later. So if the patient is asymptomatic and patient is fine, let's not jump that IO is not working. Have patience. Many of them do start responding later. Unfortunately, 12 months later, patient had one more lung nodule. This was again 6 mm nodule. Patient was asymptomatic. I continued with Nivo EP. 3 months later, again it showed partial response. Now this phenomena I couldn't understand. So I repeated PET scan after 4 months, and this time there was progression in the lung and bones both. So this was total 19 months after start of Nivo EP, we had the progression. So the question was, now what? Patient had disease-free survival of 19 months in a case of intermediate risk metastatic RCC post IO plus IO combination. Now, as I told earlier, we have plethora of options in the first line. So we have option of IO plus IO, we have options of IO plus TKI or TKI alone. And as Ved sir always says, India, not everybody, or in fact, majority of the patients can't afford IO-based treatment even today in 2024. And they are treated with only tyrosine kinase inhibitors like sunitinib and pazopanib still. So this was an interesting slide where if you have 100% of patients who are on the first line of treatment, the second line, those who will receive, reduces by half. The third line who receives reduces by 1/4. And the fourth line, less than 10%, in fact, less than 5%. If you, in India, if you see this data, this is IMDC data, but in India, if you see, this will be further down. You have second line therapy of 30 to 40% and so on and so forth. And that's the reason we are spoiled with choices, because the first choice is always the best choice, but we need to look at the second choice also. So this is the NCCN guidelines downloaded today. And if you see, one of the most important thing, what I wanted to highlight in this was subsequent therapy for clear cell histology. Preferred regimen, if you see in the second line, there is none. Why is there is none and why there is no category 1 recommendation? Because majority of the trials done are in the first line and we don't have enough data. Now, this is little paradox here. We have so much of data in the first line, so much to dissect, but second line, we have scarcity of data. And that's the reason preferred regimens are none. And if you see the other recommended regimen, there is nowhere category 1 recommendation is there. That means we still need to generate more and more data in this. So we have multiple choices in the first line and the second line, depending on the first line choices there. So if the patient has taken TKI in the first line, say sunitinib or pazopanib, and if the patient can afford IO in the second line, then you again have plethora of options. You can go to all the options which are available in the first line for second line also. In case if the patient has taken only TKI in the first line and patient is eligible for immunotherapy-based treatment in the second line, and this is what the guidelines also mention. Let's look at the patient where TKI alone is there and the patient again in the second line cannot afford IO. So you have option of TKI to TKI only. And I remember in 2010 to 2013, we had multiple conferences of sunitinib. And I remember when pazopanib was launched, I think we discussed one whole day on difference between sunitinib and pazopanib. And the second line was everolimus. So in 2015, we had 3, in fact, papers and the 3 large trials that if the patient has taken TKI in the first line, then cabozantinib versus everolimus in the second line was compared versus nivolumab versus everolimus was compared in the other trial. Now, both were published in NEJM in 2015, and both were positive studies. So what that meant was that sunitinib followed by cabozantinib or sunitinib followed by nivolumab, again, it was a good second line choice if the patient has received TKI in the first line. Now, there was this combination, as I mentioned, and as Rajat also had mentioned, that TKI plus mTOR, that is, two target therapies combination. I was very much interested in this, and I will spend 2-3 minutes on this TKI plus mTOR combination. Lenvatinib plus everolimus. In the animal models of RCC, they have seen and they have shown a strong synergy. I will not go into the basic science. This was just wanted to highlight that there is a synergy exists between when you combine these two. And in this HOPE trial, the PFS was 14.6 months compared to 5.5 months with a hazard ratio of 0.40. I would like to remind that the cabozantinib trial, NEJM article, the hazard ratio of 0.70, and in nivolumab, it was 0.72. Here we have a hazard ratio of 0.40, which is quite significant. And if you see overall survival, again, statistically significant. After the first line, patients live for 2 more years, 25.5 months, with a hazard ratio of 0.59. I think this is significant. And this is also duration of response in the lower box, which I have highlighted, is 13 months compared to 8.5 months. That means if the patients have responded, those are going to be 43% of patients. They're going to respond beyond 1 year and they will have a good quality of life. So in the second line, this table has nivolumab, cabozantinib, lenvatinib plus everolimus and exitinib. If you see the summary of all these TKI, I think progressive disease, we are always worried as a clinician that, okay, we don't want our patient to progress. So progression was least with lenvatinib and everolimus, and PFS and overall survival you have already seen. I would not repeat that. So our first take-home message today is majority of the patient in India will still go for TKI first line, and they will not be eligible or affording for second line IO-based treatments. So if the first line TKI, then second line, we have two very good options. One is cabozantinib, and second is lenvatinib plus everolimus. You can choose based on the patient profile, affordability, tolerability, and the side effect profile. Now let's come to the IO era. You patient either has received IO plus IO, or if the patient would receive IO plus anti-VEGF, IO plus TKI, and then patient progresses. So when this happens, we have two scenarios. We call it IO refractory disease or IO responding disease. So there is a definition here in the adjuvant setting and in the metastatic setting. Since we are talking of metastatic setting, let's concentrate on the lower red bar. So primary resistance to immunotherapy is defined if there is no CR or PR prior to discontinuation. I would like to add here by my personal observation that do not be in a hurry to discontinue IO. Sometimes you get later durable responses with IO if you wait for some more time if the patient is asymptomatic. Secondary resistance is prior CR or PR and less than or equal to 12 weeks from the last dose of IO. And the late progression is more than 12 weeks from the last dose of IO. Of course, CR or PR needs to be achieved. So we have now multiple options when the patient received IO in the first line, IO-based treatment in the first line. So we have a VEGF targeted monotherapy. We have here, please remember the NCCN guidelines. The preferred regimens are none, but we have many options which are other combinations. So we have a retrospective data and we have a prospective data with TKI after IO. In all the summary of the retrospective data, my apologies for this white ink, overall response rate ranges 20 to 55% is the overall response rate. And the PFS or the TTF, time to failure of treatment, is from 6 to 13 months. So you can choose your TKI based on the patient profile. This was a network meta-analysis done by cabozantinib as compared to other TKIs. Now, let me remind you, this is a monotherapy of TKIs, out of which cabozantinib stood over other TKIs in monotherapy. So again, as I mentioned, in my first takeaway, if the patient has received IO, and if you are looking for TKI option in the second line, that is what is the next best option. Cabozantinib is one option. In this network meta-analysis, they have found that it is marginally better. In fact, it can be preferred if you're looking for single TKI. And as I mentioned, lenvatinib plus everolimus remains a second option. There's the prospective data, and we have 5 different trials in the prospective data. And as you can see, overall response rate ranges from 19% to 45%. The various combinations of treatment. And the PFS ranges from 5.6 to 9.3 months. This is where we are in the retrospective and the prospective data of TKI after IO. Now, this is an interesting trial which I came across. So you have a cohort A and cohort B. Cohort A is IO plus IO, that is Nivo plus EP, and cohort B is IO plus TKI. Now, the question is that, which one cabozantinib will work better if you use in the second line. First line, Nivo EP, followed by cabozantinib. Second line, IO plus TKI or VEGF, and followed by cabozantinib. Now, which one is better? So if you see the interim efficacy result, which was presented, the overall response rate in cohort A, that is Nivo plus EP, it was 31.7%. And if you have used IO plus TKI, it was 25%. This was marginally difference. I don't see there is much of a difference in either. So you can use either of these setting. You can use the second line cabozantinib. That is what this paper said. So our patient had IO plus IO and progressed. So if we offer cabozantinib, there is a 33% chance of response rate, but we have good number of patients with stable disease. In this, I'll go back to my slide. And if you see, only 15.8% of the patients will progress. So again, a good choice. Another scenario, if the patient is fit for IO plus TKI and IO plus IO in the first line, does it make any difference in the second line that you choose? Like, for example, if I have a patient, this particular patient could have tolerated IO plus TKI also, but I selected IO plus IO. Will it impact the second line? That is the question. And this was the IMDC database consortium. It is a retrospective and a small study. But if you see, if the patient had received prior IO plus IO, as expected, now you are giving a drug with a different mechanism, the response rate was 45% as compared to 15%. This is the data, just a hypothesis generating, nothing else. It does not conclude anything. All it tells is that IO plus IO followed by TKI, you have a good response rate, consistently between 40 to 50% response rate. All the data what we have so far is from the first line where the subsequent anti-cancer therapies are there. That is the richness of data what we have. Now, the second question is, can we re-challenge IO? If we have given IO plus TKI, can we re-challenge with immunotherapy again? Now, this is a very important question. I keep doing this in the lung cancer all the time because patients have responded to IO. You don't want to give up IO. Patient has borderline progression. What we do is we give addition of ipilimumab if the patient is receiving nivolumab, or we give nivo-ipi combination. As you can see in all these trials, we have overall response rate of nivo-ipi combination is anywhere from 4 to 18%. We have hardly any CR. And in this fraction trial, nivo-ipi into 4 cycles, we have 15% response rate. I am not saying that this is a better option. What I'm trying to say that if for some reason patient is not for TKI or not for cabozantinib or not for everolimus plus lenvatinib, you can decide to give nivo-ipi combination if the patient has received IO plus TKI, and you will see some response, which is not very durable, but you will see some response. And this is the meta-analysis where 310 patients in 7 studies, overall response rate of salvage Nivo EP is 14% with a PFS of 3.7 to 5.5 months. Some response. This is a very interesting and probably my last slides. Lenva plus pembrolizumab. Now, this was a 145 patients data of phase 1b2 study 111 stroke keynote 146. And this was phase 1b2 study where treatment naive patients and IO treated patients were taken. So out of which the cohort of IO previous treated patients was 104, where 100% of patients of these 104 patients have received IO earlier. Anti-VEGF and IO combination was 65 and Nivo plus EP was 37. These patients were given lenvatinib plus pembrolizumab and the median PFS which was seen was 12.2 months and median OS as per the reporting had not reached. This was phase 1b/2 study. Please remember that. This is one drug which we need to look out for. Belzutifan plus cabozantinib. Belzutifan in the patient who have von Hippel-Lindau disease or the mutation positive, the results are far superior. But if you see overall, in the third line treatment, you combine it with cabozantinib or in the earlier lines, overall response rate is 28.8 months, median PFS of 16.8 months, which is higher than Pembro plus Lenva also. Median duration of response and median OS was not reached. So this is my second takeaway and my last slide. If the patient has been treated with IO plus IO or IO plus TKI, we have multiple second line options. We have TKI alone, where the cabozantinib is a very good option. We have a 45 to 50% response rate, and we have a duration of response almost close to 10 to 12 months. We have TKI plus mTOR combination, again 50 to 55% response rate, and the duration of response touching 13 to 14 months, and overall survival going beyond 2 years. We can do IO re-challenge with modest around 15% response rate and the PFS ranging from 3 to 5.5 months. Lenvatinib plus pembrolizumab, we need to have a phase 3 data, but I was very much intrigued because there was more than 90% disease control rate in 100% patients who were treated earlier with IO. And guys, please look out for belzutifan plus cabozantinib in future. I feel this is going to be one of the combination which is going to come in the first line also. With that, thank you so much, Ved sir, and over to our chairperson. Thank you so much.
Yeah, thank you, Amit. Excellent presentation and also thank you for educating us to how to choose a second line treatment in metastatic renal cell carcinoma. It is a tough task. We must agree that selecting second line whenever patient progresses, the patients will be frustrated, relatives will be frustrated, and you also will be equally frustrated. So selecting one is it's a tricky thing, and you have nicely brought out certain points like as a message to all postgraduates. Even if you see some radiological progression and if the patient is asymptomatic, you needn't change the treatment. It's a wonderful message you can give to young oncologists. Then I just want to ask you one question. What dose are you using when you are combining with pembrolizumab for lenvatinib? Are you using the recommended dosage or Amit? Amish,
Where recommended dose of lenvatinib we are going, how Indian patients going to tolerate?
Not
So
Dr.
12 mg is the highest which I have reached. Maximum patients between 8 to 12 mg. I would love to hear Ashok Vaid sir's experience in this. I have never reached the recommended lenvatinib in my practice.
Same here. The full dose of Lenva is very, very difficult to achieve. Patients are fatigued, they are mouth sores and GI, they are
everything.
hectic.
Yeah. But for some reason or not, the thyroid cancers, they tolerate very well. I
Yes,
don't know
you are
whether...
right, sir. No, you are right. Thyroid, I have started with 24 and people have tolerated. Although in
But-
thyroid also, there will be 2-3 patients who go up to 24.
Correct.
Remaining settle down on 12, 8. Some patients on alternate day also do keep doing well in thyroid for many, many years to come.
Yeah. So I think any other questions? We have not received many questions. I don't know whether I'm looking at the correct place to see any questions. The chat box is empty for me. Amish, be online. So we will now invite Dr. Goyal for starting the panel discussion. And we are all patiently waiting to hear how these updates are going to be incorporated in the clinical management of metastatic renal cell carcinoma. Over to Dr. Shaina Goyal.
Thank you, sir. Thank you very much. I would first like to thank the organizers and Dr. Ved, sir, for giving me this opportunity. And after these wonderful presentations and enlightening talks by Dr. Rajat, sir, and Dr. Amish, sir, I will start with the panel discussion. And with these wonderful talks, I think the panel discussion is going to go on smoothly. So I would like to first invite my panelists. First is Dr. Bivas Bishwas, sir. He's the Senior Consultant in Department of Medical Oncology at Apollo, Kolkata. Is he around?
Yes, I'm here. Good evening.
Hello, sir. Good evening. Dr. Naresh Sohani, sir. He's the Director and Head of Department in Department of Medical Oncology at HCG, Jaipur. Hello, sir. Sir was there, I think I saw him. Dr. Amit Kumar, he's the Associate Director in Department of Medical Oncology and Hematology at Medanta, Patna. Good evening, sir. Are you there?
Yeah, good evening.
Hello. And we have Dr. Tarachand Gupta, sir. He's a Senior Consultant, Department of Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Are you there, sir? So, okay, so I think we have 3 of our panelists here. With this, I would share my screen.
Yeah, Dr. Shaina, you can include Dr. Amish and Dr. Rajat as well in the panel.
Oh, sure. Thank you, sir. I think we would get a lot of great input from them. So, Dr. Amish, sir, and Dr. Rajat, sir, please be part of the panel discussion. So, are these slides visible? Shall I start?
Yes.
Oh, yes.
Yes.
Okay. So I'll start with this case that we have. This is a patient whom we have treated at our institute. So he's a 62-year-old gentleman, hypertensive. He was diagnosed to have right kidney renal cell carcinoma in April 2021 and underwent a radical nephrectomy. This was outside. But we had his histopathology report, which showed it was a clear cell RCC, a stage 1 disease. He was kept on follow-up. He presented to us in Medanta in May 2022 with complaints of cough. His status was 1. We did a PET CT scan to assess the disease status. And what we found was that there were bilateral lung nodules and pleural nodules suggestive of a recurrent metastatic disease, an advanced RCC. So, as per the IMDC risk stratification, as it was more than 12 months from the surgery and the other blood parameters were all okay. His PS was okay. His it was a favorable risk only. So, so coming to our this is the plethora of drugs that has been already discussed in detail that we have in patients for first-line treatment for advanced RCC. So I would like to start the discussion with our first panelist, Dr. Bivas. So, sir, could you please put light to what is your first-line therapy for metastatic RCC?
Okay, so we are talking this case or in general?
Sir, this patient or...
Okay, so definitely for...
You could also add on to any other case scenario which you have. Mainly, I have shared the case to just set a base to it.
Sure. So metastatic RCC for clear cell, definitely we do IMDC registration all advanced or recurrent metastatic disease. For favorable risk, I use single agent TKI because I believe there is not much of benefit in terms of PFS and OS in favorable risk group for the combination therapy over single agent TKI. TKI means the first generation TKI, the Tazopam or Sunitinib. For intermediate and poor risk, my first choice remains VEGF TKI plus immunotherapy combinations. We have 3-4 options, and sometimes double checkpoint blocker and Nivo-IP. I do prefer among the VEGF TKI and immunotherapy. My first choice always remain pembroaxitinib because of toxicity profile. Only few cases like sarcomatous carcinoma or patient with brain metastasis, my choice remains towards Nivo and Cabo combination. So that is in a brief.
Okay. So your first choice is mostly Pembro and Axitinib, right, sir?
Axitinib,
Okay.
yes.
Okay. So going next to Dr. Naresh, sir, what is your first line therapy, let's say for this patient?
So
He
good
has only
evening. So
lung
having
metastasis.
said that it's a, yeah, having said that it's the favorable, but what you have presented is just 13 months gap. So it's just a continuum, whether it's the favorable or intermediate. There's no much difference between 12 months, less than 12 months versus 13 months. This
Correct.
patient looks like quite symptomatic. So my choice will go in this patient, IO plus TKI. And as far as the drug combinations is concerned, I am more experienced with the Pembro plus Axitinib. Of late, we have started using in the intermediate high risk IO plus IO. I am not able to use the Lenva plus Pembro. The very simple reason which Dr. Amish and everybody said that if you are not able to use the required dose of the 18 milligram of the Lenva, and if you go something like 12 milligram or maybe in underweight patient like 10 milligram or 8 milligram, then we know what is the difference in the Lenva plus Pembro, the given dose versus the other combination. And we all understand that the giving the Axitinib plus Pembrolizumab is the manageable. You are able to give the dose of the Axitinib, that is the 5 milligram per milligram BD dose. So that is the reason that I prefer the Pembro combination. And I don't believe much in the PDL1 inhibitor, that is the drugs like the atezolizumab or the avelumab for the renal purpose. Hello. Hello.
I think we have lost the moderator. Looks like that.
Yes, sir. The connection has been.
So we can continue talking. So what Dr. Amish, you were telling that the lenvatinib, you were never able to use the 18 milligram. So that defeats the very purpose of the lenvatinib in the first line.
Sir, I wanted to basically give my inputs in this first line treatment. If you see Checkmate 214, the 7 years follow-up data is there now. And in that 7-year follow-up data, they have found that a favorable risk group also have done equally well as compared to intermediate and high risk. So up till now, we were using Nivo-EP combination in intermediate and high risk because that was what the data we had, but now we have a good data. And why, like, Somani sir mentioned about 12 months and 13 months. And if the patient is asymptomatic, Nivo-EP actually is a good and is the only combination which has highest amount of follow-up with excellent, Dr. Shaina, sorry, welcome back.
Yeah, sorry for that. There was a technical glitch. So I've joined through my mobile phone, and I would please request the organizers to share my slide. I've already shared them with them.
Okay.
So
Perfect.
yeah, please continue.
Yeah. So while you are sharing that, and second thing is if you see a network meta-analysis, which was done of all the trials, Somani sir, Nivo Cabo turned out to be the winner amongst all the combination. I think Pembro XZ is the first entry into market, and that's the reason we have become comfortable. But if you see in terms of the hazard ratio, Pembro XZ has the least hazard ratio compared to all others. Pembro plus Lenva has an excellent hazard ratio, but 18 mg of lenvatinib is difficult. So my preferred choice is either Nivo Cabo or Nivo EP in the first line metastatic RCC. Over
Amish,
to you.
yeah, sorry.
Can I make
Yeah,
points here?
just
So well
to
taken
add it
from
to
you, Dr.
what.
Amish.
Yeah. So many you are talking about something. I just
So
want
what I was
to
saying that
get some opinion about how will you consider starting the IO combination versus the TK plus IO combination. In some selected areas, you can prefer a TK plus IO, and some selected some indications you have to take IO plus IO as primary treatment. So, Amish, having said about that, can you just tell us how you differentiate or how you choose this IO plus IO versus TK? Any thoughts on that?
Sir,
yeah, so 2
one,
points are there to make the comment.
sorry,
Who
yeah.
is supposed to talk? Am I make to comment or Dr. Amish?
Somani sir, please go ahead.
So one point excellently told by Dr. Amish is that the just 4 cycles of the ipilimumab is the finish. You continue only the nivolumab, less toxicity to the patient with the IO plus IO versus TKI plus IO, whichever TKI or IO combination you take. So that is probably the reason that we go in the favor of the IO plus IO. Another reason is that when you don't need much response in the very beginning, like less symptomatic patient, maybe it is the IO plus IO combination which may be preferred over the TKI plus IO. Again, the problem with the cabozantinib plus nivo is again maintaining the dose of the cabozantinib and balancing it with the side effects of the cabozantinib, which usually comes within 2 to 3 months. Very disturbing. Again, even the 40 milligram dose becomes a very difficult challenge, especially in combination.
Sir, I think they are not able to share the slides. So a very good points, Dr. Amish sir, you had brought up, which was one of my questions in the subsequent slides on using Nivo EP for a favorable risk group. So to make it clear, yes, it is not a recommended regimen when it comes to favorable risk group.
I think there's some technical glitch at Dr. Shaina's end.
So, sir, I'll just Amit here from Patna. Sir,
Yes.
for favorable risk, substantial disease burden, and patient is not so symptomatic. I didn't think so. Nivo EP is the thing you will be preferring to start in the favorable group also.
I think I agree with what Dr. Somani sir has mentioned, that your volume load, the metastatic disease volume load should not be that much that you need immediate response rate. One. Second thing is I give in a lot of working people with a low volume and relatively less symptomatic, because once you give 4 cycles of Nivo EP, after that you can give 4 weekly Nivo also, Saturday to Saturday, and they continue working.
Yeah.
Somewhere TKI, as Somani sir mentioned, whether you have a Cabo or Lenva or XZ, every day they are reminded of the side effects of TKI. So I use Nivo EP in these patients. Yes, after this 7 years and 8 years follow-up data of Checkmate 214, I have started using it in favorable risk also. Till that time, I was not using because it was not approved.
Thank you, sir. So I would ask, just give me a minute, sir. I think there's some problem with the slides.
Dr. Shaina, you can ask
Okay.
questions and we will
Yeah,
imagine
sir,
the
I think
slides, not to worry. Yeah. Go ahead,
right.
please.
So I think they have not received my slides. So I'll just continue with my questions. So like this patient that what you mentioned, so what we started with for this patient was nivolumab plus cabozantinib. And this was started in May 2022. And after 6 cycles, we did a response assessment, which showed that there was a good response to treatment. And we continued him on the same management. So before I go on to further discussing about this patient, there was one more thing I wanted to bring out in the initial discussion which we had, because we discussed and we are talking about the newer updates and whether it changes your clinical practice tomorrow. What was brought up by Dr. Rajat is, Dr. Rajat around, sir, since you presented the Javelin 101 update data, would you consider avelumab in any of your patients as first line RCC before we move forward? Is Dr. Rajat there? Okay, we'll go to Dr. Bivas.
Yes, so use the available, right?
Yes.
Yeah.
Yes,
So
sir.
data
So
is
when you
there. It is
consider
one of
available.
the yes, it is one of the approved option. I have used in around 5-6 patients, but not in favorable risk, both in intermediate and poor risk. Tolerance was not at all an issue. The only issue is the logistic that every 2 weeks of injections and definitely the access. But yes, I have used and had a good outcome. So this is one of the choice for me for
What
intermediate and
about?
poor. But now I have, yeah.
Thank you. So what about Dr. Naresh, sir? Have you used or would you use it considering this update data? Are you convinced about using this regimen?
I never use map. I am not using it. Probably I will not require to use it in the future because I feel its data were weak since beginning. Is the PDL1 inhibitor, and probably the PDL1 inhibitor is the weak drug or the weak immune checkpoint inhibitor in case of the RCC.
Right. So I think the updated data also did not show any overall survival benefit, whereas the other studies have. So that also goes not in favor. So another thing which I want to bring out from Dr. Rajat's presentation was the biomarker analysis. So like we discussed that there is no definite biomarker and we have these plethora of drugs and we've been discussing on how to choose. So there has been some studies as presented where they're trying to even look at PDL1. So though it was not a very good marker and even irrespective of PDL1, there has been response. I just wanted to show you this study which is going on. Sorry, the slides are not there now. There is a CARE1 trial which they are coming up with in Europe, in which they are trying to randomize patients between IO plus IO combination versus an IO plus TKI combination for PDL1 positive and PDL1 negative. So maybe this trial could in future give us probably a indication to how we can choose the right agent with a test as simple as the PDL1. So coming to our case further, our patient had at the end of 2 years, he had an ongoing response. Though in between the treatment plan, during this treatment, he tolerated well other than some grade 2 toxicity, skin rash, grade 1 nephritis. One more problem that he developed, which I want to discuss, was a perianal abscess, for which he was, though managed conservatively.
Can I
So
make a
Dr.
comment?
Amit, sir? Yeah, sir, please.
Okay. So basically, there is no clear-cut data regarding this, but we usually used to stop at least 1 or 2 weeks, I'll say, before going for any surgical intervention and keep it further post-surgical intervention for a week or so. We keep the TKI as a stop for these patients in most of the cases.
Okay.
I think the
And so when you restart,
only Cabo has
sorry,
a
sir.
very long half-life.
Yes,
XC and lenvatinib are shorter. So
Shorter, right.
yeah, Cabo needs to be, but Cabo on the other hand does not have as much of a VEGF inhibition. So between the two, Lenba versus XC, so Lenba has a much more profound VEGF inhibition, probably best in the class. And so that would be the concern. I think minor surgeries or all that may not require too long an interruption. And as it is, the half-life is just about 30 hours for Lenba.
Right. So now going back to our patient. So as I said, at 2 years, he had an
China, just switch off your video. The audio will become better. Just switch off your video.
I would like to ask how many patients to see who progress.
China, if I may suggest, just switch off your video.
Naresh Somani, sir.
I couldn't get your point. Can you repeat it?
Oh, okay, sir. So, sir, how many
Your voice
patients
is, I mean, it's
whom you start?
broken in between.
Oh, I'm so sorry for the technical issues today. Sir, am I audible clear now?
Yeah, right now, yes.
So what I was asking was, sir, how many patients on first line therapy, like was presented by Dr. Amish, sir, do progress and go on to the second line therapy in your clinical practice?
So yes, maybe within 4 or 5 months, 30–40% patient, they will have the subjectively or objectively progression of the disease. And sometimes it becomes very difficult to understand whether it's a clear-cut progression or we should try to give some more times for the immune checkpoint inhibitors to work. And it's many times we all feel that it's the judgmental error. Ultimately, they have the real progression. So one has to be very vigilant to understand the symptoms of the patient. And maybe 30–40% of the patient, they have the progression of the disease within 3 to 4 months, or you may call it as the primary refractory disease. But making the comment on the previous point of the biomarkers, looking at the bar of the 50% or more with the axitinib, Pembro or Lenva plus Pembro, and with fortunately or unfortunately PDL1 is of no use. Presently, I don't think that we need to bother much for the biomarker-based selection of the combination. So we are just happy with the TKI plus IO combination to begin with.
Yeah, very true. So whenever the only thing is just continuing with the previous discussion, Dr. Savali, it's about yeah, she has come back. Okay.
When we need to stop the drugs for some toxicity, we should not forget that even the immune checkpoint inhibitors has a long half-life. They may remain in the body for the 3 to 4 weeks, depending on that schedule you are giving and what dose you are giving. So it is not simply the anti-VEGF action of the TKI. The immune checkpoint inhibitor for the major surgery may also be a problem.
Right, sir. I think that's also, we have to check the blood parameters and everything. Okay. So next question that I would like to discuss, though it has been very extensively put forward by Dr. Amish, sir, but just an opinion from my panelists here. How do you choose post-progression on IO plus TKI, second line cabozantinib versus Lenva plus everolimus? Dr. Bivas?
Yeah. So it's a difficult choice actually. There is no accurate comparison. My first choice remains cabozantinib if not used in first line. So for an all non-cabozantinib indication, I use cabozantinib second line, especially after this IO-TKI combination. Keep the everolimus and lenvatinib combination third line. My experience is not that good because of the toxicity. So ultimately, all patients had to reduce the everolimus, some has to stop, and even the lenvatinib. It ultimately boils down to 10 mg in most of the cases. It's not easy combination to use.
Okay. Oh, okay, sir. Sir, but then the post second line, do you think the patients would, like as shown by Dr. Amish, that it's always the lesser number of patients who go to the subsequent line of treatment?
Absolutely, that's right. That's right.
Okay, so Dr. Naresh, sir.
So IO plus IO in second line.
No,
I
sir,
have not
I think
used
could you
it,
please go back to
definitely.
the slide? So we are discussing the previous question, but yeah, one back, please. Could you go back? Yeah, so sir, we are discussing this. How do you choose between cabozantinib versus Lenva plus everolimus in second line for probably this patient who has progressed? Or he's on Nivo Cabo,
So
a patient who
probably,
progressed on probably
so
Axi plus
probably,
Pembro.
yeah. So probably cabozantinib is for everyone. Lenva plus everolimus is for the select patient whom I feel that they are in the PS1 and can tolerate the toxicity of the this combination, which may be really a problematic with the dose of the Lenva plus everolimus. So maybe that the 40 milligram of the cabozantinib is to start with. Try to aspire it to go to the 60 milligram if feasible. Otherwise, I'm happy with the 40 milligram.
Okay. Dr. Amit, sir, your take on it?
Yeah, so I completely agree with Sumani sir. So if the patient is having a high burden disease and a fit patient, as with a initially young patient, I'll go for lenvatinib plus everolimus. And most patient, though we have to modify the doses most oftenly, but somehow with managing the toxicity, I have got few patients which are going good on lenvatinib plus everolimus. And usually, I can keep cabozantinib after the next line. But if the patient has a very poor performance status or like that, might be cabozantinib. In that case, I'll be giving upfront.
So a fit patient, your preference is second line Lenva plus everolimus. So I think, yes, the data response rates as shown by Dr. Amish sir is also slightly higher for Lenva plus Evro versus cabozantinib. We don't have a direct comparison. So please, can we go to the next slide? Next slide. Yeah, just skip it. Next. Next. Yeah, so now I would like to just ask your opinion on anti-PD-1 inhibitors beyond progression. I will show the two slides, the next two slides, and then take your opinion on that. Could you go to the next slide? Next slide, please. So as this was shown by Dr. Amish sir also, that how beyond progression on Nivo, ipilimumab when added has shown some response rates of in the tune of 13%, 10 to 13%, and it can be an option for patients who have a minimal progression. Next slide. This was also shown the combination of Lenva plus Pembro. Next. And the third one was use of Atezo plus Cabo, which was actually a negative trial. So with this available data, Dr. Amit sir, let's start with you. How would you will you consider IO beyond progression?
So definitely in that case, if nivolumab is used initially and there's a minimal or mild progression only, in that case, I'll surely add ipilimumab to that patient and again reevaluate. But if there's a frank progression or there is a great progression, I'm going to switch over to TKIs-based therapy.
So you're not very convinced with the Lenva plus pembrolizumab data phase 1b2 data that was shown?
So right now, no, I'll wait for the full trial data.
I think none of us are very comfortable with doing that at this moment. Dr. Naresh sir?
So in second line, these all present options. None of them are the preferred as given by the NCCN guideline because they are simply the extrapolation or taking these all blocks options from the first line. We don't have their study. That's why the algorithm is given as the IO naive patient or IO treated patient. And as this trial also, you are showing Atezo plus cabozantinib with the negative trial. So my choice most of the time remains, if the IO is not in the combination previously, then maybe the cabozantinib plus Nivo or maybe the Pembro plus axitinib. Again, my choice remains if I have to use the combination in the second line.
Okay, thank you, sir. So next slide. Next slide. Oh, this also already discussed by Dr. Amish sir, belzutifan. I think this is a new drug to look forward, already approved for VHL patients, and we would soon be, it is already and now approved even for the other clear cell RCCs. Next slide. Next. Yeah, so just this is the last point of discussion. How do you treat a metastatic non-clear cell RCC? Since this was also one of the abstract presented, I wanted to get an expert opinion on this. So starting with you, Dr. Naresh sir, if you have a patient of non-clear cell RCC now, what is your first line?
Yeah. So 3-4 points. So let's say that I am talking about the papillary RCC, which is the most common among the non-clear cell. So the MET inhibition or the MET role has been now clearly proven in this. So that probably if I have to use the single agent, then the cabozantinib is the best choice. Otherwise, the combination of the cabozantinib with some IO is probably the next choice. And a lot of clinical trials are also ongoing. And let me share with you that at my center also the Samita trial, which is the combination of the durvalumab plus serlotinib. MET exon expression-based clinical trial that's also running. So in the clinical practice, probably it's the cabozantinib because that's the MET inhibitor drug, or maybe the cabozantinib plus some immune checkpoint inhibitor. That's probably the next choice in the clinical trial. And of course, the single agent TKI like sunitinib, they always remains a choice or the treatment option for those patients who cannot afford or cannot get the IO-based treatment.
Right. So it's mostly cabozantinib based IO combination is what you would choose. Dr. Bivas, sir?
Yes, I think all options there as discussed by my other colleagues, but one option I have also used in a type 2 papillary, and there is three I think phase 2 data on Arlo and we have used almost in 15-20 patients, good response and good PFS. Whereas I have 5 patients who is more than 2 years on Arlo. So there is a lot of.
So your voice is not very clear. Could you just please
Can you hear me?
repeat that?
Can you hear me? Hello.
Okay. So,
Hello. Yeah, Dr. Amit sir, what's your take on that? Non-clear cell RCC first line, what do you prefer?
So what Dr. Vivas was telling and what is our experience also, Erlotinib and bevacizumab has got a very good response, which we see in papillary RCC. Though surely we
Okay.
studied, as Dr. Sumani said, cabozantinib plus either nivolumab or anything in the front line, and thereafter erlotinib and bevacizumab is the thing which I say the patient is having a very good response for papillary one, and for the sarcomatoid variant, as already discussed, is the immunotherapy has got a much better response.
Right, right, sir. So erlotinib plus bevacizumab is one of the things. Okay, so I would just present one study. Next, please. Next slide. Yeah, this was the earlier data where the response rates are poor, as we know. Next slide. Yeah, so this is the study. I just wanted to show a keynote B61 study, which was presented in ASCO 2023, where they have used pembrolizumab plus lenvatinib plus with not clear cell RCC. Next slide. And see the response rates which they have got. So it's for papillary and chromophobe, the papillary RCC, the response rates are as high as 54%, and for chromophobe, 28%. So probably with this data, I think we can consider using lenvatinib plus pembro for these patients with, and we do need more data on it, but this has shown very good responses. Next slide. Yeah, next. So just concluding, as we discussed, no biomarkers present, though we do need more studies on predictive biomarkers for IO plus IO versus IO TKI. Second line and beyond, no evidence to suggest which is better, no category 1 recommendation sequence. And as said by Dr. Amish sir, we don't have so much of data on second line because it's very difficult and long studies which are required. I think what we need is more real world data to choose the right regimen. And a Lenva plus Pembro could be one of the active combinations for non-clear cell RCC. Thank you, everyone. And I'm very sorry for all the technical issues which were there.
I don't agree with your last line of the conclusion, madam.
Okay, sir. Sir, it was just one of the options.
Non-clear cell, you cannot say that the Pembro plus Lenva is the best. You need to dissect them. Let's say, as Dr. Amit said, that the sarcomatoid. It's the immune checkpoint inhibitor, highly sensitive disease. Whether you give the single agent or in the combination, even if you do the sub-analysis of those patients, the clear cell in the first line, those patients who were having some sarcomatoid component, they responded well to the immune checkpoint inhibitors. And if you look presently, the most common chunk of the non-clear cell, that is the papillary RCC. It is the cabozantinib single agent, some combination, or it is some other MET exon-based inhibitor treatment, which is probably the way to go forward.
Yes, sir. Sir, I think yes, for sarcomatoid, rightly, as you said, the study did not take sarcomatoid patients, sir. I completely take your point, sir.
Yeah. Okay. Yeah. Have you finished, Dr. Shaina?
Yes, yes.
Yeah.
Sir,
Thank you.
Thank you.
Thank you so much for. Though we had some technical issues, but altogether the discussion was very fruitful. And now, and as Dr. Somani rightly pointed out, for sarcomatoid, I feel that IO is the best option. And now what we see is the more and more non-clear cell histologies are getting IO or TKI combinations as the first line treatment. So now today we have very good discussion, starting with Dr. Rajat's presentation, the updates on various conferences, especially ASCO 2024. He has given us an overview about all the trials updated as well as the biomarkers which we are all patiently looking for. And followed by Amish Vora discussing about the second line options, and Dr. Shaina very nicely incorporated all the latest results to the in the clinical practice and how to incorporate them in the day-to-day management. With this, I think we can conclude the session. And Dr. Ved, you can take over now. And once again, thanks for your invitation.
Not much to say. Thank you everyone for joining in, and we had 140 live attendees at any given point in time, and my thanks to all the faculty for taking this time out, and all the joinees, and making it so educational. It was a lot of learning for everyone, for me as well. And learning never stops. And of course, thanks to Rajesh, your team, Priyanshi, Anshika, and everyone. And also our knowledge partners. Principally, this was sponsored by CIPLA, ESI, Fresenius, and INTAS. My sincere thanks to all of them, and thanks to all the faculty once again. We can close the session now. Stay safe, good night, and see you soon with another topic.
Right, sir. Thank you. Thank you.